Okay. All right. Good morning, everybody. Welcome to a not sunny, beautiful day in Nashville, Tennessee. Hope everybody's well. Today is February 27th, if you can believe it. We are almost out of February and almost into March. Time is moving quickly. I'll give you kind of an update on the COVID stuff in just a minute. But today's guest is Amanda Myatt Brock, who is a Senior Vice President of Clinical Services at the Mental Health Cooperative here in Nashville. We'll go through that in just a minute. But hey, Amanda, for the first couple of minutes, we just generally talk, and I was looking at the stuff behind your head. So you have a big thing that says music back there. Do you like music? Why do you have that back there?
I do like music, but I'm not talented in music, but my 9-year-old daughter is. So this is our bonus room where she gets to practice her mandolin and all that good stuff. So.
Mandolin? Okay, so what else does she play? Just the mandolin?
Just the mandolin right now. She also likes to sing. So her goal is to be a famous singer and buy mom and dad a nice house on the beach so we can retire.
I'm all for that.
I am too.
So can she sing? I mean, I know you're talking to a lot of people right now. Can she sing?
For a 9-year-old, she's probably not bad if you are a big fan of modern country music. So that's her thing.
All right. Can she sing the national anthem?
Not yet.
Not yet. Okay.
Yeah, she's working on that one.
All right. So, every so often, particularly if people do a good job on this program, no, I'm just kidding. We really do. When we were before the pandemic, we were inviting young people, kids, to come in and bang the gavel to start the meetings at the council. So, and if she can sing, we would be happy to let her sing. Is she good with singing in front of a group of people at this point?
Well, she's done it in front of her school, but that's about it. So
okay,
she did okay with that.
Okay. Well, so keep that in mind. That was of the many new things we've tried with the council since I've been vice mayor. That was kind of the most fun.
I bet.
And it was sort of, I'm trying to remember how it got started. I can't even remember the first one. Either we invited the young person up or they were already in the chamber, or we had somebody come in and say, bang the gavel. So then other people started saying, hey, can my child come do it? And we had council members do it. It was really a lot of fun. And it made for a good start to the meeting and people felt good about it. We need to bring that back. So, it is about 4 minutes after 10. Welcome everybody again. Our guest today is Amanda Myatt Brock, who is the Senior Vice President of Clinical Services at the Mental Health Cooperative. This should be a really interesting conversation. And in a minute, I'll explain why, but a very important conversation as well. Amanda, I will tell you that last week we had Dr. Battle who's head of the director of the school system. And that was very impressive. So you're following on the heels of that one. A couple of things, new COVID numbers, 155 new cases. Okay, so that's kind of where we've been. One additional death. I know that we're moving to 65 plus in Nashville. The state is at 65 plus. I know they had trouble yesterday with some of the phone lines, just people trying to get in, or at least the system crashing because so many people were trying to sign up. Just hang with it. I think they approved Johnson & Johnson yesterday. So I think that's coming. So light at the end of the tunnel. Just everybody hang in there. Okay, just hang together. Councilmember John Rutherford is on today. Welcome, Councilmember. And former Judge Dan Eisenstein, who used to be head of the Mental Health Board, is on. So welcome, Judge Eisenstein. All right, I think I got through all that. Amanda, welcome. Thank you for doing this. First question always is tell everybody, for those on the call who may not know you, where are you from? How did you get to this? That type of thing.
Great. Well, first of all, I'm so happy to be with you guys and talk about something that I'm very passionate about. But I'm from Middle Tennessee, grew up in Mount Juliet, and have worked and lived in around the Nashville area since the mid-90s. And I'm a licensed clinical social worker. And I have to say, I was one of those kids in college that didn't know what I wanted to do when I grew up, and decided to go to social work school right after undergrad, and immediately found what I enjoyed, which was working with people who have mental illness, chronic and severe mental illness, who often find themselves in a crisis situation and incarcerated. My second year of graduate school, I had the pleasure of interning at the public defender's office, and immediately, I remember calling my parents saying, okay, I found what I want to do. I want to work with people who are incarcerated, who are mentally ill. My parents were a little taken back by that, but I found that so many people ended up in that system because they weren't properly diagnosed. They ended up inadvertently going through this system that unfortunately, continued to traumatize them. And I knew that there was ways that we could help if we could identify earlier, and had the pleasure of working with some really talented attorneys who really believed in working with social workers like me, which was great. And then had the pleasure of working as a crisis counselor at the mental health co-op right after graduate school. And I spent a couple of years back at the public defender's office after that, working with juveniles. And then in 2001, the co-op, mental health co-op, called me back and said, we want to develop a criminal justice specialty. And I was like, the stars have aligned. That's exactly what I want to do. And I've been at the mental health co-op ever since. I've had several different roles. Like I said, I oversaw their criminal justice programs, specifically with the mental health court. Hope y'all can still hear me.
That's okay. We got you. We got you. You froze for just a second, but it's okay.
And then I became the director of crisis services, did that for many years. And now I'm, like you said, the senior VP of all of our clinical services, which the crisis department, our criminal justice specialty, still fall under my umbrella. And I just have to say, each day is a challenge, but I love it. I love it because it is a challenge, and I think we're helping a lot of people.
So when you worked at the public defender's office, who was the public defender? First time in the state?
When I first started, it was Carl Dean, and then Ross Alderman when I went back. And so I see Mike Engel on the call. Mike is one of the key people who hired me back, when I couldn't wait to get back into that arena.
Well, I never trust Mike's judgment. So, there you go. So, my brother was the public defender as well. Did you know that?
I remember hearing his name.
Yeah, he was there before Carl was. So, and the program is still standing, which is good after my brother. So that's a good thing. Okay, so tell folks, I know there are people on who know how your program works, but for those who don't, and this is why this call is actually very important. Tell us how the Mental Health Cooperative, what they do in connection with the police and with the sheriff's department.
Sure. Well, let me first tell you, the Mental Health Co-op is a non-for-profit. We were started in 1993 to really serve the most severely and persistently mentally ill in Nashville. And we're still true to that model today. In addition to our Nashville location, we now have 10 other locations throughout Middle and East Tennessee. Our crisis services, which is what is most common in terms of the interaction with police and sheriff's office, includes our mobile crisis team, which are people who are master's level clinicians who will go assess individuals who are having any sort of psychiatric crisis. That could be they're suicidal. They are hearing voices that are telling them to harm themselves or others. It could be, a person at a homeless camp who is acting really bizarre. It runs the gamut. So we have our crisis services, and we've had that since the beginning of our organization. And then, as I mentioned before, we also developed a criminal justice specialty, and that's what got us involved with the sheriff's office. In 2005, we became the psychiatric provider inside the Davidson County Sheriff's Office facilities. So I have a whole team of clinicians who treat those individuals who end up incarcerated. In roughly 2001, we developed a partnership with Metro PD where if they encountered somebody who they deemed had a mental illness based on their interactions, they could contact our crisis team for assistance with that individual. And that could involve us going to the scene or the officers bringing them to our location. That has continued to evolve over the years. And in 2017, we were able to get some additional funding from the city to enhance what we do. That then led to us getting state dollars to create a crisis treatment center, which is a 24/7 place where individuals can walk in. If they have a mental illness or their loved one is having a mental health crisis, they can come straight into our walk-in center and get an immediate assessment. And then we can start initiating treatment if that needs to happen right then and there. Or officers can bring people directly to that location. And we, at that time, realized that a lot of officers were taking people to emergency rooms. They were also taking people, unfortunately, to jail for minor misdemeanors, knowing that they had mental illness, but they were doing that because they were having extreme wait times with people if they took them, let's say, to an emergency room to get mental health treatment. You know, if you're a person with mental illness, you go into an emergency room, they're dealing with trauma first, you know, the motorcycle accident, the person who's having a heart attack, the mental health cases get triaged down. Well, the whole time that officer's still sitting with that individual. And so when we created our crisis treatment center, our premise was, let's create a place where if officers recognize there's a mental illness, they can bring them to us. We beefed up our staffing so that we can say, thank you, officer, for bringing them in. The officer gives us a report, and then the officers back out in under 10 minutes. They have their own separate entrance so that they're not bringing somebody into a crowded lobby. They come in and we can get them out. And since we opened that center in 2019, we've been able to get officers back out in under 10 minutes. We're getting a little bit to 15 minutes right now, and I think that's due to the COVID screenings we have to do. But we're really proud of the fact that we're able to get those officers back on the street very quickly because they don't need to be involved in the assessment and treatment of mental illness. The mental health professionals need to be involved in that.
Okay, so let me stop you for a second and let's, because this I know is a question from people. So obviously an officer can bring an individual to your facility and you can screen them and then the officer can leave. So they have the ability, I guess that, okay, so maybe a couple of questions. One is, I know people are going to be interested to know if you need to go to the scene, how that works, of the scene of whoever is called.
Right.
But then I guess the second question is, does the officer have the ability to make the determination on the spot to go, I believe this is a mental health situation and I believe I need to go to the crisis center? Two questions in there.
Sure. First of all, if let me answer that second question first. If an officer is on the scene with an individual and they think that there's a mental health component, it could be anything from, the person's threatening suicide or they recognize hallucinating, they call our triage line more often than not. They talk to a counselor, and while we're talking to that officer, we're looking up and saying to see if we've ever had previous contact with that individual. We can do that in real time, and then we can say, Officer Jones, we really think, it'd be good for us to assess that person. We typically give the officer the option. We can either send somebody to the scene or they can bring them to our location. The officer, that's the discretion that they really have, and we rely on them to make that determination. More often than not, they prefer to bring them to us because, well, it's going to be quicker. And they know that we have not only mental health counselors, but we have nurses on 24/7, so we can do a nursing assessment. The times that they prefer us coming to the scene are often if they think that if the individual is so agitated or paranoid that they're worried that the person, it may involve a restraint or them having to, really force that person into the car and they don't want to do that. Or if there are other circumstances going on where there's family members involved and they really think it's important for us to meet with the family members on the scene, and the family members come into play to determine whether we go to the scene or not. And I will say, in terms of going to the scene in recent years, often gets called out on, of course, barricade situations where somebody is inside threatening to harm themselves. So SWAT has a whole negotiator team that handles that, hopefully trying to de-escalate that situation before, the guys in the big suits go in. And they've been calling us. We have a law enforcement liaison. I dedicated one of our leadership positions to be a law enforcement liaison on our crisis team. And he goes out on a majority of those calls with the SWAT negotiators and helps facilitate gathering information to help in that negotiation.
Okay, so there was a question about training of the officers. Are you involved, or somebody from your entity involved in the training of officers to recognize when that mental health call should be made?
Yes, we are, and we have been for many years. So training involves several different components. There's standard classroom training that occurs at the academy that members of my team do. That includes things like recognizing basic signs and symptoms of mental illness, suicide risk factors, those types of things. So they get the classroom training. And then one thing that has evolved over the recent years that I think is a great addition to the training is what we call reality-based training. Officers get a lot of reality-based training on techniques about restraint and when to go hands-on. But the reality-based training we're involved on is on verbal de-escalation when you know somebody has a mental illness, and how in role playing. I mean, it's intensive where we have I send a team of mental health clinicians who go and actually act as if they have a mental illness. And then they are senior officers who are observing and making sure that the officers are following police procedure, but then we give them feedback on how well they're doing in regards to their verbal de-escalation. So that's been an evolution over the last couple of years. In addition to that, we also do some in-service training. Officers have to get, I think, I can't remember how many hours of in-service training a year, mental health component. So a member of my team does that. It's typically, I think, just an hour or an hour and a half as a kind of a refresher. And the topics tend to change, but they always have a mental health nexus to them. And then I will say, increasing some of the role play, the scenario-based training, and looking at doing more of a 40-hour, what's called crisis intervention team training for officers. So that's in discussion right now with Chief Drake's administration.
Yeah, I was going to ask you, and we lost you for a second, but
Okay.
I think the idea was 1 or 2 hours a year is not all that good. So
Right.
I think, one of the recommendations would be, doesn't it need to escalate a little bit more in terms of the number of hours? And it sounds like you're talking about working with Chief Drake on that right now. That
Exactly.
sounds like a good thing. Let me ask you another question that comes up, and that is, this is a tricky one. So, and it's when that call is made, somebody calls 911, somebody calls the police come, but I know there are some people that said calling the police is going to escalate the situation. Call the mental health cooperative instead.
Mhm.
That, I understand both sides of it, but kind of explain in your mind how that works. I know that, we do hear from people that said, don't call the police. That's
Right.
just going to be, that's not what we want. We need somebody, this is a mental health case. But we're never sure, nobody's quite sure what the situation is going to evolve into. And that's what we're trying to figure out. So how would you answer that question?
Sure. So let me first kind of explain just kind of how the volume of cases works currently. And so you get an idea. I think the perception is that police are involved in most of these crisis calls. And that's not necessarily true. So we get roughly 5,000 phone calls to our crisis triage line in a month. Of those 5,000 calls, anywhere from 700 to 800, we deem we need to do a face-to-face assessment with those individuals. And of that 700 to 800, it's usually, right now, it's averaging about 100 of those involve the police. The rest are being handled with either us bringing the person into our crisis treatment center, which is most common, or directing that, or sending staff out. Now, I will say in recent years, when we send staff out, we will often ask the police to meet us at the scene, just because, I have one counselor who's going to that location, and while they're a trained mental health clinician, they're not trained to assess an environment necessarily for an immediate risk to others. So they will often have officers just meet them at the scene. They'll go up, handle the situation, and then, if we deem pretty quickly that we don't need the officers, we let them go. Now, in terms of how we make that determination, when we get that call, we're looking at, have we had past history with that individual? Is there a report that there might be drugs involved, in addition to mental illness? Anything that could increase the risk factor for our staff as well as the person who's on the phone. And if there's any indication that there's a risk, then we're going to ask police to go with us. Or we may, depending on the nature of the call and what's going on, we actually may call, while we've got a mental health clinician on the phone, have another team member call the police because it's escalating very quickly and we can hear that. I have seen, and I've said this many times, can having the police there escalate a situation? It can, absolutely. But I've also seen where it de-escalates the situation too. It just depends. And it's hard to predict. I think a lot of it has to do with how the officer presents himself or herself. It also may have to do with what's going on with that individual who's in crisis. I mean, if they're paranoid about the government, which is a pretty common delusion with people with schizophrenia, and then you have a law enforcement officer show up, that could escalate it. If they've had a prior bad experience with law enforcement, obviously that can escalate it as well. But unfortunately, particularly with the combination of drugs, which we've seen more and more on these crisis situations, that presents a higher risk to anybody who's involved in that scenario. And that's why we often have to get police involved.
Okay. All right. And that makes sense. And I know that's a difficult call. And I know that, again, different philosophies on this. And this is where we talk it through and figure out, for everybody's safety, what's the best thing to do. Let me ask you one other question, then we're going to switch over a little bit to the sheriff's department.
Mm-hmm.
Okay, so police are called to a scene. Mental health cooperative comes out to the scene as well, and there's kind of an understanding and assessment of kind of what's going on with the situation.
Mm-hmm.
How is, maybe explain exactly who is kind of in charge of figuring out what is the right thing to do? Does everybody kind of work together? Ultimately, is the police officer's call, or how does that work? How is the determination made? It's like that person needs to go be taken to jail, or this is truly a mental health situation, we're going to take them this way. How does that get decided?
Good question. I would say 95% of the time, if not higher, when there's a mental health clinician on site, the officers tend to take a back seat because they've called us because they recognize there's mental illness. And that clinician is looking at, does this person are they presenting with acute symptoms? And we're trying to evaluate, can we refer them to outpatient care or bring them back to our office for some programs we have that are where they can stay overnight and get immediate evaluation and on medication? Or are we going to have to involuntarily commit this person against their will to a psychiatric hospital? Most of the time, officers will defer to us and say, this is, obviously mental health. You make the recommendation about what needs to happen, and they will defer. The only time we are honestly seeing officers currently say, wait a minute, we're going to have to take them to jail, is if there's an outstanding warrant. That individual harms somebody else, it turns into a domestic, and the victim of that domestic wants to prosecute. Then, at that point, they feel like their hands are tied and they're going to go ahead and take them to booking. Now, if we have been able to complete an assessment and still think that person needs inpatient treatment, the officer may take them to booking, but we're communicating with the sheriff's office and the team over there to say, once they're booked, we've already made a referral to the state hospital, which is where they have to go if they're incarcerated, and we'll start that process. So they may still get to the inpatient treatment. Or if they don't meet that inpatient criteria, the mental health team at the jail, that again falls under my area of responsibility, will ensure that they get seen and get treated by a psychiatrist or nurse practitioner.
Okay, so that's a good segue into what you all do for the sheriff's department.
Mm-hmm.
All right, so Okay, so understanding the situation with the police and an incident where, the police are called, mental health cooperative is called, or maybe the mental health cooperative is not called, but eventually the police are now taking someone to the sheriff's department to
Mhm.
book them into the jail.
Mhm.
Um, and we've had the sheriff on who's talked about the behavioral health treatment facility now in the new jail.
Mhm.
Tell us how that works, because you were talking about, well, you may have already called ahead and person needs to go someplace else. What is the role of the mental health cooperative as police are taking somebody in and somebody is we're about to determine whether somebody is put in a jail cell or is diverted into the behavioral health treatment center?
Treatment center, okay. Well, first of all, when somebody is booked in, when they are brought in, they are immediately screened by a nurse. And then as of October of this year, we also have mental health clinicians 24/7 in booking. So once they see the nurse for any medical issues, they immediately see a mental health clinician. That clinician then determines, do they have a mental illness? Do they need treatment? And that treatment could involve, immediately getting on the list to see the psychiatrist or nurse practitioner. It could involve, if there's any concern about suicide, putting them on suicide watch, or a follow-up. Say, if they're still here in a couple of days, we need to kind of follow back up and see, because often when people are booked in, they may be intoxicated or they may not be wanting to talk, and we know that we need to follow up with them. Also important to note, we can look at their history when they've been incarcerated before, if they've been incarcerated before, and know if they've had a mental health history prior, and that's valuable information. My team can also look and see if they have ever had contact with mental health outpatient services with us. So that helps as well as crisis contacts. In terms of determining who is going to go the regular jail route or the behavioral care center, it's a two-pronged approach. First, if they have a mental illness, we flag them as, hey, this person has a qualifying mental illness for the behavioral care center. The very next morning, and they typically stay in the booking area. The very next morning, the public defender, the district attorney, and a member of my staff from the behavioral care center meet really early in the morning. They look at everybody who's been booked in, and if their charges qualify them to go over to the behavioral care center, then they will start working them over. So they never get dressed into the jail issued jumpsuit up to booking. They get over to the behavioral care center. And the charges, I mean, the DA and who's assigned to that has been very open to being, listening to what the clinician recommends as to, I really think this person would be a good candidate. But the target is people who are charged with a misdemeanor offense.
Yeah.
I believe we have taken some people who've been charged with an assault. If the victim of that assault says, look, my husband was, this happened because he's been off his medication and I really want him into treatment. So they make contact with the victim, and if they agree, we move them over to the treatment side. So we're looking at not only do they have a mental illness, but also the legal charges that they're charged with.
Okay. And okay, so you've been doing this. I know that the behavioral health treatment center at the sheriff's office is the new facilities. It just opened. But have you been doing this? Has Mental Health Cooperative been doing this for a while, or is this something kind of brand new in terms of how this works?
Well, in terms of that process I just talked about, whether, going into a diversionary program, obviously that's new with the behavioral care center opening in October. And I will say opening a center like that during a pandemic was challenging because arrests are down right now. And so there's, thankfully, there's not as many people coming in. But prior to that, we still had the process where we would identify if they had a mental illness and be responsible for providing treatment while they're incarcerated, as well as helping identify people who may be appropriate for other programs like mental health court or the various treatment courts, the drug courts, the Cherished Hearts is for people who may be victims of sex trafficking, that kind of thing.
Okay, so I know it's relative with the new program or with the new facility, it's relatively new, but how do you measure, or how are we going to be able to measure whether this is having an impact? And let me preface it by saying some of the numbers we've seen from the sheriff say that as many as 50% of the people coming in have some type of mental health problem.
Mhm.
And one of the big concerns I know through discussions with public and community groups is this revolving door of people who, go in, who are arrested, go into the facility, come back out, get arrested, go back in. So I know that it involves a lot of help with wraparound services, trying to help the individual, and sometimes that works and sometimes it doesn't.
Mhm.
How do we measure whether this is working?
That's a great question. And I think there's no easy answer to that. I think one of the things we look at is, obviously recidivism rates. If we identify those high utilizers or repeat offenders, and we have those, we should look at not only their overall recidivism rate, let's say in a year's time frame, but we also need to look at, are we decreasing the number of arrests that occur for those people? Because I would argue, while they may still end up incarcerated, if we're having less of those and a greater period of time before they end back up, then I would still count that as a success. And the reason I say that is that a lot of these individuals, particularly our chronic offenders, are people who have multitude of issues. They're homeless, they're mentally ill, they often have an addiction issue. They have, they may not be receptive to the type of treatment that they need. And just keeping them engaged in treatment can be a big challenge. But we have to the little steps. For instance, I had a client years ago. He had all of those issues I just outlined. He'd been homeless for 30 years. He went to mental health court. And this was way back when Judge Fishburne was the mental health court judge. And within a couple of weeks of getting diverted into mental health court, he had housing. He was on his medication, which was an injection, but he still liked to drink. He had been an alcoholic for 30 years. He actually came to court floridly intoxicated at 8 o'clock in the morning. And the judge is looking at me going, what in the world? I said, but hold on, Judge, he's here. He actually came to court. And if we looked at this man's history, he had a history of repeated failure to appear, panhandling, that kind of thing. And while he was intoxicated in court, we need to honor the fact that he came to court. It was important to him to come to court. It was on his medication, and that he had not picked up a charge in 3 weeks. That was success for this individual. And we had to continue to evaluate that particular individual's needs. And while he still got arrested periodically, it was not at the same rate as before the intervention. So I just tell you that story because these types of situations, they're complicated, and I wish I could wave a magic wand and once they're treated and they have good wraparound services in the community, say they're never going to come back into the criminal justice system. But that's not reality for many of the folks we see.
And I think that's so important for people to understand that it's not a one size fits all. It is, every case is different.
And
all right, so go ahead.
Well, I just want to say, we talk a lot about relapse in the recovery community for people who, they fall off the wagon if they're, an alcoholic. Mental health is very similar. People will get on medication, they start feeling better, and then they think they don't need the medication again. And so we see that cycle, and that's often what leads to many of these folks cycling also back in the criminal justice system.
Okay. All right. So one more question, and then I'm going to get into some of the questions that were asked over the week. All right. So if we gave you a magic wand, like you were talking about before, or let's just say that we elected you mayor, okay?
Oh, please no.
I may be voting for you. All right. So if you could change something, and the magic wand probably is not a good thing because I know how you would deal with it then, but is there something in the system now that you would think that we can address better, that you would tell us to try to do? What would you try to change at this point? I think the system sounds really, really good, but what can we do better?
I think the first thing I would say is resources. While Nashville, when I think about other cities, we are, in terms of mental health in this arena, we have a lot of actually good resources, but those resources haven't been able to keep up with the growth in our city. And that's, I mean, our city just, the population skyrocketed, as you all know, and the mental health resources haven't necessarily increased at the same rate. I think in regards to that, I think the increased partnership with Metro PD, where we can pair a mental health clinician with officers to go out and respond jointly, because sometimes, best training, officers are not clinicians. They're not meant to be clinicians, and they may miss that, hey, this person I got called out because they are a suspicious individual is not necessarily suspicious because they're about ready to do a criminal act, but there may be a mental health nexus. I think if we could get more clinicians paired with officers, then we will have a greater likelihood of diverting people before that first arrest. Because we do know once that individual, particularly with mental illness, has that first arrest, they're likely to have repeated interactions with police. Just this week, I was on a call with Denver, a city very similar size to Nashville, and they have developed a model that I think is something we ought to emulate here, which is they have a mental health clinician that is assigned to each police sector in their city. And that clinician will go to roll call and they will ride with an officer for that shift. The next day they come out and ride with a different officer in that sector. So they go out on all calls. Of course, if it's a mental health call, they are the first team that gets dispatched. But if there's not a mental health call, they'll go to whatever call's going on. And the director of that program said that the benefit they have seen is that on those calls that are dispatched, they have no report of mental health issues. That clinician is often saying, hey, wait a minute, officer, I know this individual, or this is a mental health. And they're able to divert more people that way. And then they also have some other support services where if that officer and that clinician deem that it doesn't need their level of expertise, they can call in another unit to come and kind of take care of more of the psychosocial issues related to homelessness and help get that person connected. I think Nashville has the right climate right now to look for models, to do models like that. We just need the resources to be able to do it. We certainly, I think, have the cooperation with Chief Drake to do things differently than we are currently doing.
Okay, so I'm going to get to a question about Chief Drake in a minute. I think my question to you would be, okay, so city may be in the mood for this, obviously budgetary issues and so forth going on. We have a budget that'll be coming up within the next 2 months, and then the council will have to look at it. How do you all, or do you go through the police department or the sheriff's department to get this information into the mayor's office and ultimately to the council, which approves the budget? If you all need more resources and the program seems to be working, who is getting that information in to say, if there are dollars that can be found within the budget, this is where they need to go? How do you all make the case to the right people to make sure somebody's listening?
Great question. I would say we need to do a better job at that, because honestly, up until like I said, 2017, 2018, we got no money from the city. All of our funding comes from the state and from Teen Care, and that worked for a while. But with the city growing, we're at a significant deficit. We work a lot with the Metro Health Department and worked with them to get some initial funding that we get from the city for our crisis treatment center. That's about $400,000 for staff. Those dollars go completely to staff to help us manage that particular unit. So I would say that's one thing we need to do better as an organization, because we haven't really navigated that very well. But the Metro Health Department is primarily our voice on these issues right now.
Which one? The Metro Health?
Metro Health Department.
Okay. Okay. Well, you've got I think you've got Councilmember Rutherford on the call. So we're going to make sure that he and I talk at some point and make sure that we relay this information, because I think it's very, very important.
And I will say, anybody who wants to see what we currently do, if they want to come see our crisis treatment center and hear about, what it's like for somebody who comes via police or walk in, we can get my contact information out, and we're more than happy to give tours and explain from the ground level what it's like.
Okay. All right. And that may be very, very important, particularly for some of our folks from our budget committee and the mayor's office, I think, as well. All right. So we have, let's see, we have about a little less than 20 minutes. I'm going to go through some of the questions, and some of them I know that you may not necessarily be able to answer directly, but generally, and I'll just go through them. Number one, the recent shooting on I-440 of the young lady, the nurse. The question was basically, some people immediately said that was a failure to provide mental health services to the individual. Now, you can't talk about the case, but the person who at least is alleged to have fired the shots, or the two people in the car, both very young. Tell us about how the system works with particularly young kids and in juvenile court. Maybe that's the best way to answer that.
Yeah, well, I will say, I think, like you said, I can't talk about a specific case, but research is out there, and people who work in our school system and juvenile court will tell you this, and I firmly believe this as a clinician, is that often issues related to children's mental health manifest in elementary school, middle school, and they're often mislabeled as a behavioral problem. Children, they aren't going to come talk to you about their feelings. They are going to act out, and often that acting out can be in more aggressive, seen as aggressive. So they get labeled a problem child, and people are missing the fact that this could have a mental health issue, or it could be related to trauma. So I think we've got to do a better job of identifying at a much younger age, and typically elementary schools. We need to look at what's happening with our children when they're 6, 7, 8, 9, before they get to those teenage years and are skipping school and then committing criminal acts. There are some initiatives to really try to get more social workers and mental health clinicians in the school system. To do a better job of our teachers about mental health issues, but then also having resources that are embedded in the school system to help.
Okay, and maybe that was where my next question was going to go. Resources within the school system. The schools have enough stuff going on trying to maintain, even without a pandemic, trying to deal with all the different issues they've got going on. The training of either counselors within the system, the administration, the principal, or the teachers about recognizing early on that situations with children that need some review. I guess that's maybe the best way for me to say it. It's like, this child needs some help now, instead of waiting for 6 years until they get into middle school and then it becomes worse. So do you all work with the school system in any way to try to deal with that?
Not as robust as we used to. And I'll be perfectly honest, a lot of that came to funding. We used to embed therapists in a lot of the schools that had a high concentration of children who had identified mental health needs, or, a school may have reached out. The problem is the only funding for that is typically Medicaid funding. And we couldn't continue to sustain that. We're losing money on that particular service, and had to pull back a lot. Now, in some of the surrounding counties, the more rural counties, the state has created these initiatives to pay for clinicians to work in some of the deemed higher risk schools or underserved schools, and we are part of that initiative. I don't think Davidson County has yet been identified, but I'm not as directly involved in that area of our business to be able to speak for sure about that.
Okay. I'm taking notes as we talk. Okay. The next question that I've got is, someone asked about the closing of mental hospitals. This goes back, some years, but the facilities closed down. There's been some indication that led to an increase in homelessness. The question, I guess, would be, do we need to go back to something like that after review, after some years of having closed them down? Was that the right decision, or do we need something kind of in between, I guess would be the question.
Yeah, that's a great question. And I will say, the deinstitutionalization movement, I firmly support that. There were people who were in hospitals that didn't need to be. The problem is the level of services in the community, quite frankly, isn't always there for some of these individuals. So I think there does need to be a middle ground. I also think we need to look at um, being able to treat people longer and get them stable in a hospital before they're back out. Right now, psychiatric hospitalization, the days of long-term psychiatric hospitalization are gone. The average length of stay in an inpatient psych hospital in this state is 5 days. So a lot can be done for some people in 5 days. Some people you can stabilize pretty quickly, but other people need a lot longer stabilization period, and you need to have time to do a really robust discharge plan. And that discharge plan, it needs to include housing. It needs to include not only how they're going to get their medication, but the additional support services. How are they going to get transportation? It's the basic, activities of daily living that they need help with. And that's really hard to put together in 5 days for many individuals. I will also say something that I think is a little bit controversial, but I believe in being honest, is that our commitment laws need to be looked at again. Because right now I can only commit somebody if they are an immediate threat to themselves or others. And that standard is sometimes very hard to meet. And one of the hardest things as a clinician is to tell the parent of an adult child who has schizophrenia that, look, I know your child is very sick. They're a 19-year-old having their first psychotic break, but they're not doing anything right now that I can force them into treatment, and they're not willing to engage in treatment. I have to tell that parent, I have to wait till they're presenting an immediate threat to themselves or to somebody else before I can take that away from them. And also knowing that particularly something like schizophrenia, the longer they go in that psychotic state, the harder it's going to be to get them back stable. So I think there needs to be some alteration of that while still protecting somebody's rights, but a way to maybe temporarily force an outpatient treatment. Say to this individual, I know you don't want medication, but we've got to try this, or you are going to have to go inpatient.
Do you all have an advocacy arm? Because that I would guess would be a state law.
Mhm.
So working with the Department of Mental Health and Substance Abuse, is there a way to at least get that across? I know it's, yeah, there may be arguments on both sides, but you're trying to do, based upon your clinical review, you're trying to do something that's responsible. Do y'all have an advocacy arm?
We do not.
Okay.
We currently do not. We rely heavily on, making recommendations to the Department of Mental Health or working with some of the advocacy groups. But again, that's a very controversial thing. NAMI is a great organization, the National Alliance for the Mentally Ill, and they do a lot of advocacy, but it also can be very controversial to say that you're going to force somebody into treatment. And I think there needs to be clear parameters if we move in that direction so that people's rights are protected. But I just think that's the commitment standard we have in Tennessee is very similar to all 50 states. And it makes you wait till they're, like the analogy, if we looked at cancer, for instance, it's almost like you have to wait in the mental health world that they're at a stage 4 of a diagnosis before you can intervene in many cases. And, we wouldn't do that with a cancer patient.
Right. Okay. We can talk more about that offline, in terms of how you can, get that message through, because I think that's important, both at the state level and at the city level. Okay. Next question. Impact of COVID. You've already talked some about it on this call, but increase in mental health issues during COVID, I would guess yes. Yeah.
Yes, I'm afraid so. The March of last year, we saw a slight decline in people accessing our services at the early days of COVID. That quickly changed about a month into all of this. And we are seeing, volumes that are higher than we've seen before. And then nationwide, I think, the preliminary studies are there's higher rates of suicide. We know that there's higher rates of fatal drug overdoses that have been going on. Particularly in Nashville, since January to now, we've seen a rise in that. I worry about the mental health of our kids, because often, I talked about how sometimes it's underdiagnosed, but often the school is the one who does pick up on that they have an issue. And, we're kids not in school right now, we worry about what's going on with them. And we have seen the only place we've seen a decline is in referrals about kids into crisis. But I think that largely has to do with kids aren't out and about, and things aren't being picked up on as much. So COVID, I think I think we're still going to be dealing with the mental health impacts of COVID for many years to come. We also know that people who have mental illness, clinics were shut down for a while, or they didn't have the level of face-to-face. A lot of interactions with their therapist and their psychiatrist, and even what we have case managers or their social worker is remote. And while that's great, it's often not nearly as good as that actual face-to-face interaction.
I think it's important that you noted that, because we so often live right now and live in this particular moment, and we're going like, we got all this stuff and we've got all this pressure and we've got to get through to the other side. That understanding that the impact of the pandemic is going to be around with us for a long time. Everything from when you hear, are people going to continue to wear masks for a while? And the answer is probably yes, to understanding that the impact of what has happened to us over the last year is going to have long range impacts on our mental health. I think that's important for people to know. Okay. You mentioned this before, relationship with Chief Drake, the police. I think the question was, how's that going? Kind of a new relationship, more use of your organizations, more assessments. And then I've got a couple follow-up questions from that. Chief Drake has been on this show. I've known him for a while. Good, really, really good guy. Change in relationships. Do you think there's going to be more use of your mental health efforts?
Absolutely. I will say, even back when Chief Drake was just named interim chief, he immediately had some people in leadership within his team reach out to us and start conversations about what we need to do differently. So he didn't wait till, he officially got the job to say, we know we need to do something different. Since he was officially named, I don't think we've gone a week without having some really good direct dialogue with him about ways we need to improve. He is committed to developing a co-response program where we would have a mental health clinician paired with an officer and maybe piloted in one area. In fact, just earlier this week, the call I had with Denver was with Inspector Imhoff from Metro PD was on that as well, because as many of y'all know, Chief Drake has tapped him to kind of do some more innovative things. There's been more open communication. There's been a lot of honest dialogue about things that haven't worked in the past. And I've seen a definite shift in culture to look for, well, why can't we divert more people versus, well, we can't divert more people because they've committed a criminal act. It's more like, but how can we, that person who, for instance, is trespassing, talk to the business owner who wants to prosecute them and say, hey, instead of taking them downtown, are you okay? We've identified mental illness. Can we take them over to the crisis treatment center? Those kinds of conversations are happening with Chief Drake and his leadership. And I firmly believe in the next 3 to 6 months, we will have at the very least, a pilot program, and hopefully will lead to more people being diverted into our treatment program versus going downtown. Our first step is we've started working on a MOU, a Memorandum of Understanding, to really look at how we're going to share information, because obviously there's certain things I can't share with them, but there are things I can, and data points I can share, and vice versa. And so we've been going back and forth, and I think we're getting close to finalizing that. And then I mentioned before, I have a dedicated member on my leadership team who's a law enforcement liaison, who's been working a lot with Inspector Imhoff just in the first 2 weeks that he's been in this new role.
Interesting. Somebody just sent a message through chat about talking to police about, they were talking about, police not directing traffic, having other people direct traffic so you can move resources or move people to places where they need to be. And I guess maybe that's I love the fact that there's more discussions and more talking going on. Maybe this is a bigger question in terms of you know, relooking at how we do certain things, improving overall public safety, but improving. I mean, I think people do want to get people to the right places for help, and obviously there's a move for less incarceration, particularly if all we're doing is recycling people through the system, and it's the same people, and they're not getting any help, and they just keep being picked up.
Right.
And so I guess maybe this might be the last question, but the question is, do you feel like it sounds like we're moving in the right direction in terms of people more at the table, more discussions? And if so, I understand the need for additional resources, but do you think we're going in the right direction, or I mean, do you need some of us to push a little harder to get there?
And you froze up a little bit, but I think I got the question. I think we're definitely moving in the right direction. I think the biggest struggle for us right now as an overall system is having the financial resources to have the staff that we need. Both, I don't want to speak for the police department. It's, there's budgetary issues across the board, but for instance, I've shared with you, my agency's losing $1 million on the crisis line of business, that's specific, just the crisis treatment center. If I look at our overall crisis services, it's going to be a $2 million loss. Thankfully, we're able to continue to do that right now because we're a successful non-for-profit, and we're just using some of our reserves to shore that up. But I can't sustain that year over year without our board going, we got to scale that back and be able to live within your budget. So one of my biggest worries is if we're confident we will be, that's going to divert more people into us for treatment. And we already know a majority of those people are uninsured. I mean, 60 to 70% of the people we see each month are uninsured. And there's a ceiling of funding that we get from the Department of Mental Health to take care of the uninsured. And it certainly isn't covering the gap we have right now.
All right. So it sounds like we're doing pretty well overall. We're heading in the direction that maybe we should, but there's going to be a need for additional resources. And the other thing I would add, and this is probably the last thing before we end the program, is the understanding of what you all do and what we can do, and get that understanding out there. I know I didn't understand the full thing until the other day when you were on the program. And as soon as I heard it, it's like, we need to talk more about this. Mm-hmm. So we're going to find, I'm going to try to find more opportunity organization in front of people so that they can learn more. There's a question about expanding Medicaid. Let's see, I just saw it come through. Would expanding Medicaid help? Mm-hmm. Probably. That's an issue, obviously, for the state of Tennessee, but I assume that would help if you got more funds in that way. And you just froze. So there you go. That's okay.
I was just saying expanding Medicaid would certainly help. I think, cities that have expanded Medicaid have been able to have more robust services that we've talked about. So that would certainly be a benefit. And we are open to, the mental health co-op. We've kind of flown under the radar. We're not good at promoting what we do, but definitely anybody interested stakeholders who want to know as we do and city, I'm more than happy to come speak, and members of my team come speak as well, and bring some data. I mean, I can speak all day long, but I know people are going to want to see what are the data points you can show that it's effective.
Well, Amanda, we have found you all now. We had heard about you, but now we know who you are. We really do appreciate you being on this call. This is really, really important. I will need to get in touch because obviously we have budgetary issues coming up. There's a lot of people interested in this. This is very, very important. You did great. thank you so much for being on this call. Amanda Brock, Senior Vice President of Clinical Services at the Mental Health Cooperative. Again, thanks everybody for being on. We will be on next week with Chief William Swan, the head of the fire department. So please join us then. Amanda, I'll be in touch because I need to get more information from you, and you're now on our radar screen. So now you can't hide from us. We know where you are. Again, thank you for your time. Everybody, thank you. And good luck with your daughter and her mandolin. Okay.
Thanks, everybody.
And thanks, everybody. Have a great rest of the weekend. Bye.